Hello, my name is Natalia Novoa-Walton, and I would like to discuss social functioning of school-age children with an ADHD diagnosis in a classroom setting. ADHD is the most common neurobehavioral disorder diagnosed in school-age children. Symptoms appear in toddlerhood and continue into adulthood. In the U.S., 6 million children between the ages of 3 and 17 were diagnosed between 2016 and 2019. Prevalence is higher in boys that are non-Hispanic Black and non-Hispanic white. So how does ADHD affect social functioning in a classroom setting? And how can teachers and schools find ways to incorporate interventions into their curriculums? Behavioral symptoms of ADHD present as developmentally inappropriate for the child's age. It includes inattention, hyperactivity, and impulsivity. Cognitive regulation impairment is related to genetic and environmental risk factors. This creates difficulties with emotional regulation that may affect social functioning. Deficient emotional self regulation involves low tolerance for various emotions, leading to intense emotional behavioral manifestations. Brain physiology is also different in the ADHD brain. There is a desynchronization of alpha and beta waves. These are associated with wakeful relaxation and alert attentiveness and thinking. The default mode network shows higher activity during rest periods than during focused tasks performance. Deficient deactivations of the DMN during periods of focused task performance results in inattention. Areas of the brain show less outgoing information flows when compared with non-ADHD brains. The flow of information also differs between control subjects and ADHD subjects. There is a neurotransmitter dysregulation of norepinephrine, serotonin, and dopamine. This regulation is connected to changes and differences in the gut-brain axis. This dysregulation of neurotransmitters in the GBA is due to inadequate gut microbiota. This affects brain activity, development, and behaviors such as those seen in children with ADHD. Working memory maintains and processes information in the short term. It is involved in higher order cognitive functions. Deficiencies of working memory disrupt encoding of information as a result of inattentiveness. Encoding is associated with memory storage and maintenance, and it presents as inattentiveness and forgetfulness. There's also a faster decay and inefficient maintenance of memories. Executive functions modulates attention and behavior. It's associated with working memory, inhibitory control, and cognitive flexibility. It regulates impulsivity. It is a necessary cognitive feature for academic tasks, social, and emotional functioning. It is a disruption of cognitive skills that is found in all of the domains of development with ADHD. It is a predictive tool for peer acceptance due to social functioning being heavily reliant on executive function. These are the types of ADHD. Subthreshold is similar but does not fulfill criteria for diagnosis. Combined includes inattention, hyperactivity, and impulsivity symptoms. And then there's also impulsive, inattentive, and distracted. There are other types and presentations, but the ones listed here don't have peer review material for support. There are higher rates of autism spectrum disorder in children with ADHD. Emotional problems can increase the risk of comorbid psychopathology. There are also higher rates of comorbidities like ODD, depression, generalized anxiety, and mood disorders. ADHD and gender. Presentation is similar between boys and girls in terms of deficits and outcomes, but most research was conducted with samples of boys. Any studies conducted with samples of girls found similar deficits in behavioral, emotional, and social functioning, but there were no significant differences found in academic achievements or social functioning. Girls are more likely to be diagnosed with inattentive subtype and be less likely to display symptoms of depression and ODD. They're less likely to display academic problems or have learning disabilities, and show less severe external symptoms while manifesting more severe internal symptoms. Boys were consistently found to display more symptoms in the school setting and have higher rates of disruptiveness, gross motor activity like fidgeting, and aggression. ADHD assessment follows the guidelines from DSM 5 and use standardized scales along different domains. Assessments include medical, developmental, and academic history, and must consider family history, bullying, and any child abuse. Observations are done for at least 6 months throughout different domains. Assessments are done using parent observations, teacher observations, and determinations by doctors and professionals. Parents are more sensitive to symptoms of anxiety and depression, internalized symptoms, and comorbidities. Teachers are more sensitive to disruptive and external behaviors and setting specific behaviors as well. Here's a list of rating scales. The Vanderbilt Assessment Scale is the most commonly used, following the DSM-5 diagnostic criteria for children between ages of 6 and 12. Also uses parent and teacher observations with a healthcare professional determination. The CBCL is also noteworthy because it includes a youth self-report option along with other multicultural options. Interventions for ADHD aim to improve functioning rather than symptom reduction, and a multi-component approach is better than a singular intervention approach. The behavioral component includes parents, the household, school, and teachers. The medication component is usually focused on stimulant medication that has shown the greatest effect for symptom reduction and overall increased functioning. Combined interventions use school, home parenting trainings, along with medications, which have been shown to have higher response rates and lower the need for other medication to treat comorbidities. Treatment adherence is a problem, but greater adherence to treatments and protocols results in larger treatment gains. There are some complementary and alternative interventions. Dietary interventions include elimination diets, which reduce systemic adverse reactions to allergens and triggers. Probiotic supplementation of medications have positively affected the severity of ADHD symptoms. Exercise programs are designed for children during physical education and are associated with a significant reduction of externalized symptoms. Classroom setting. ADHD is considered a disability under the Americans with Disabilities Act and Section 504 of the Rehabilitation Act. Working memory and executive function dysfunctions affect the way information is retained, affect timing and time reproduction errors, self-organization, test-taking, and problem-solving. They affect behavioral inhibition and sustained attention exceeding 10 seconds, which was found to challenge the time reproduction. And they also affect gender-related presentations of symptoms such as aggression, rates of disruption, and gross motor activity. Social functioning is directly linked to academic functioning. ADHD is a significant predictor of social impairment. Social functioning deficits is experienced by the majority of children diagnosed with ADHD. Limited observational learning and attention to social feedback during social interactions will affect social functioning. Peers are influenced by teachers since they may take cues from the way teachers treat students. They value or exclude children that seem different, interpret increasing intervention based positive behaviors by the teacher as disingenuous, and teachers show gender based expectations, perceive boys to exhibit more severe ADHD symptoms than girls, and influence subsequent ratings affecting social functioning of genders with the same degree of impairment. Interventions may improve the sociometric judgments of adults and teachers, but not of peers. Children with ADHD are at high risk of perceiving relationship to other children as poorer. Increased attention by the teacher can lead to peers becoming irritated or resentful towards children with ADHD. Peers can also respond to the symptoms associated with ADHD. Inattentiveness could lead to missing social cues, leading to poorer peer judgments. Severity of emotion recognition problems predict emotional and peer problems. The ESR can also affect social functioning and negatively impact peer judgments. Time reproduction deficits can make time appear to move slower, causing impatience and worsening social functioning. Social functioning programs help develop or increase a feeling of belonging to enable feelings of psychological and social safety. The main goal is to fulfill the basic psychological need for a child to bond with peers and adults in a school setting, more specifically within a classroom setting. The Mosaic program is a social functioning program that uses social learning theory and teacher strategies to improve peer group dynamics and efficient social behaviors. Implementation is to the whole class with selective support directed to children with ADHD. Another component of Mosaic is child led creation of safe spaces in the classroom. It allows psychological safety through play in order to gain sensory and emotional regulation independently. Available resources within the classroom are for all students to be used as needed, enabling self regulation and belonging. These are designated areas by the children and can include quiet corners, dark tents, fidget toys, and mindfulness activities. Another program is the Collaborative Life Skills Program. Its main goal is to reduce ADHD symptoms and increase social skills. It uses parent and child training, teacher consultation, and implementation of daily reports of classroom behaviors. Additional programs include Best in Class, which aims to increase engagement in instructional activity, Banking Time, which is reinforcing positive teacher student connections. Play and the social brain are an important part of socialization and development in childhood, including self generated activities. It has a positive effect on executive functions by allowing children to stop, look, listen, and feel as part of self regulatory playful interactions, promoting social maturation. Social functioning through play is applied by learning how to interact, learning acceptable social cues and behaviors, learning what is not allowed in group settings. Implementation can be recess in a more frequent or direct way. Some solutions and future directions are adding peer assessments and interviews along with previous raters. This helps identify symptoms and comorbidities that may not be readily obvious to parents and teachers. It helps to recognize the reasoning as to why judgments do not change as part of intervention outcomes. Programs that extend interventions to non ADHD children with poor sociometric judgments of ADHD children should include this feedback. The reasoning behind an unchanged judgment could identify weaknesses in a program or implementation errors. Redefining developmental milestones along a spectrum and not an expected definite point. Individualization of development through social and academic understanding of the student can use mixed age grades. It allows children to move through school curriculums at their own pace. Children are no longer impaired or deficient, but moving at their own level of skill and readiness. Mixed age classrooms increase social and emotional understanding through social learning. They gain a sense of comfort, security, and independence when they are expected to move at their own pace and skill level. Schools or classrooms designed by children should have an input on an ongoing basis from year to year. Children are seen as subjects and not the architects of their environment. Evidence based treatments, social functioning, and behavioral intervention programs beyond middle school are scarce, and a lack of support decreases treatment adherence. Adolescents benefited from CBT, which has seen a reduction of ADHD and comorbid symptoms, improved executive function and working memory, with a medium and large effect sizes. Benefits of CBT were still observed at a 3-month follow up from the beginning of treatment. Programs should be an available source for adolescents with ADHD within schools or as school collaborative programs. Some limitations found in the literature were diagnosis and treatment of children experiencing no or mild symptoms of ADHD may lower academic and social functioning. Harmful side effects increase or continued distrust on mental health professionals and skewed program outcomes. There's also a limitation in the diagnostic criteria defined in the DSM 5 since it's focused on younger children and not adolescents. Adolescents should have their own research category due to the different expectations of autonomy and organization. Comorbidities in younger children may not be as obvious or present when compared to adolescents, which is another reason to include older children in research samples. Older samples for diagnostic criteria and research could expand diagnostic criteria to include well being and self awareness. Additionally, research samples demographics still include a higher number of boys across sociodemographic groups. Boys and girls have the same level of impairments in school functioning, but different internal and external symptoms. This difference can limit the support provided to girls, potentially increasing the chances of explaining away the lack of academic success as just being lazy. This is an ongoing issue since academic success is a distinctive criterion for recognizing a need for assessment. Diagnosis is not the same as assessment or observations. Diagnosis requires developmentally inappropriate behaviors to be observed. This may not be as obvious in girls. Social functioning in preschool and young elementary school children may yield an unreliable diagnosis. Different maturity ranges affecting social functioning dependent on quote unquote normal development. Comorbidities or other developmental disorders can also yield a false positive diagnosis like autism, highlighting the importance of follow ups and reassessments throughout a child's life. Research is mostly conducted in settings that are not classrooms. Behaviors representative of ADHD will differ from one setting to another. Clinical or unfamiliar environments may change the behavior no matter the developmental or disability status of a child. In conclusion, some of the most noteworthy people of past and modern times have been suspected of having or have been diagnosed with ADHD. Descriptions associated with ADHD include words like deficit, but can be considered a superpower. Importance of teachers cannot be understated, for they are the core of how children experience the classroom. Peers are only a part of a child's functioning in the classroom, not the entire picture. I once heard ADHD being described as a Ferrari engine, but the brakes of a bicycle. ADHD does affect social functioning in the classroom setting. Teachers in schools can find a lot of ways to incorporate evidence based interventions into curriculums to supplement established parent home interventions for school age children. Thank you so much for watching. I hope you learned something. Thank you.
bedtime.
Mommy, mine is not done yet.
Stop it!